welcome everyone to this next session of Revolutionizing Healthcare, and this next in many regards. It's our first after our summer break, and it's also one where we try a few new things, just as I said, and we have a few new people on board, which Mihaela will present to you in just a moment. But our overall topic today is AI education for clinicians. And as we have a lot of clinicians here live with us and also on our panel for today, I'm looking forward to a very engaging conversation and lots of questions that we can answer today and ask many more. And with this, I would like to hand over to Mihaela to introduce you all to the session and our new colleagues.
Thank you very much, Andreas, and a warm welcome to all of you. I am Mihaela van der Schaar, and I'm a professor in Cambridge, bridging AI, artificial intelligence, machine learning, and medicine. I have started this engagement session, Revolutionizing Healthcare, with an aim to engage revolutionary clinicians like you and think together through the hard problems of medicine and healthcare that you are trying to solve, and see if machine learning can provide solutions to some of them. This is an endeavor that we started already 3 years ago. So if you are new to our engagement sessions, I would like to invite you to take a look at our resources of the last 3 years, and you will see a variety of sessions dedicated to a variety of topics. And I hope some of them will still resonate with you. And if you have ideas about future sessions, please drop me a line and we would be delighted to engage with you and the ideas you have. For quite a long time, I was interested in trying to understand really what AI skills should clinicians and medical professionals learn. When should they learn these skills? And as the field of both AI as well as medicine are evolving, what new skills should be introduced and at what pace? And while really I collaborate with many clinicians from various different countries on different specialties, and you will see some of the conversations we had if you are taking a look at Revolutionizing Healthcare. It is really this topic of how to teach and at what level to teach and engage clinicians with AI that has kept me busy for a long time. In 2019, I was part of a review here in the UK called the Topol Review, which was led by Eric Topol, which was commissioned by the NHS Health Education England to explore how to prepare the healthcare force here in the UK through education and training to deliver a digital future. And I was the lead on the AI side of this Topol report. And while I think that this report has made an important step along the way, I think that many questions remained, and many questions remain to be answered. So this has been really an agenda that was very, very important to me as a machine learner, AI researcher, trying really to build tools to empower clinicians like you. And I was very fortunate because in the last couple of summers, we have had a variety of brilliant medical students joining us and do research in our lab to bridge the world of medicine and AI. And this past summer, I was joined by 2 medical students, Tim Oosterlinck and Tim Schubert. Tim Oosterlinck comes from KU Leuven, where he is a medical student, and Tim Schubert comes from University of Heidelberg, where he's also a medical student. And together, we not only did research, but we also tried to really think about how really AI should be incorporated in medical education and in medical profession throughout your professional life. And together we envision this session, which is going to be run by the 2 teams. So with this, I'd like to introduce you to them and let you in their hands to run the session.
Thank you so much for the kind words, Mihaela. So as we move on, we're today joined by a great panel of experts, and I would like to introduce each of them to you. So let's start with Professor Robert Stevens, who joins us from Johns Hopkins University in the USA. He's a physician scientist and a practicing intensivist at Johns Hopkins, and his research combines methods from data science with mechanistic modeling, advanced neuroimaging, and physiological measurements. We're also glad to be joined by Dr. Liam McCoy today from the Universities of Toronto and Alberta in Canada. And Dr. McCoy is a resident physician in neurology at the University of Alberta, with ongoing research focused upon ensuring the effective and ethical integration of artificial intelligence in health system context. And his research also focuses upon ensuring that the technology we use works to help rather than harm health equity for marginalized patient groups. We're also glad to be joined by Dr. Ari Ercole from the University of Cambridge, who's also a faculty member at the Cambridge Center for AI in Medicine. And he's a research active intensive care consultant with a particular interest in digital medicine and the use of analytics to support clinical care. As CCIO, he leads the clinical integration and implementation of digital, including the development and implementation of AI solutions across the hospital. We are also joined by a psychologist today, which is great. His name is Matthias Laupichler at the University of Bonn in Germany, and he works at the Institute of Medical Education in Bonn. He uses AI applications for his own research in the field of medical education, and one example is that he tries to compare man-made versus AI-generated questions for medical exams. And of course, we're joined today by Professor Mihaela van der Schaar, who is the John Humphrey Plummer Professor of Machine Learning, AI, and Medicine at Cambridge, and is also the director of Cambridge Center for AI and Medicine, and has been a really great mentor to Tim and me over the past summer. So without further ado, I would like to hand over to Tim, who will explain how today's session will work.
Thank you, Tim. This is a bit longer session than normal, 1 hour and a half instead of 1 hour, as we want to make sure that we have enough room for the roundtable and also to address your questions from the audience. If you run short on time, there will be a timer you can see, and with a short sound, just to let you know that you have to wrap things up, just to make sure that we're sticking to the timetable of the session and give every topic and panelist the time to share their views. The topics we're going to discuss today are the essential skills that clinicians will need, and also how we will integrate this AI education into the medical education. And lastly, for those who have completed their formal training, how they should continue their education and stay updated and relevant. And remember, there is a Q&A chat available for you where you can upvote the questions that resonate with you the most. And in addition, we also have interactive polls.
Speaking of polls, we would like to bring up the first one right now. And we're starting poll to get to know everyone in the session better. So here you have a poll session, and you have 2 minutes to answer that poll on your experience about AI. Okay, and as you can hopefully see on your screens as well, most of you are actually somewhat familiar with AI already, and some are actually very familiar with AI. We also find that most people are actually using ChatGPT quite a lot, apparently, and some are also using other machine learning models. But most people actually think that AI will not replace certain medical professions. And I think it will be very interesting to hear from our expert panelists now, who are actually, most of them are clinicians using AI.
Yeah, luckily we have experts here who specialize in AI within medicine. Let's just meet them first. And I would ask, with our tight schedule, that our panelists limit their introductions to 2 minutes. I suggest we start with Professor Stevens. With your role at Johns Hopkins and also having a robust portfolio spanning informatics to precision medicine, would you start us off by giving a short introduction into your work, please?
Sure. Can you hear me?
Yes.
So good morning, everybody. It's great to join this panel, and very happy to engage in questions and answers and discussion with this large group of participants. So I'm a physician and a scientist. I am trained in anesthesiology, intensive care medicine, and currently practice at Johns Hopkins University in Baltimore in Maryland. So as you'll see, there's some overlap between the kinds of activities that I'm engaged in and those of Ari Ercole, who's also on this panel. So my dream is that my profession, intensive care medicine, will disappear, right? That this will become an obsolete, branch of medicine. And why would I say something like this? I say because I think a lot of what we see in intensive care is predictable and preventable. I think that many of the conditions that we treat are conditions that can be, if we had the appropriate data, the appropriate modeling, can be actually forecast and that we could put into place therapies, interventions to prevent people from becoming critically ill and requiring intensive care. I also think that we can implement methods to accelerate recovery from intensive care. And I think that many of the monitoring technologies that we deploy in an ICU can increasingly be deployed outside of the ICU. So for all these reasons, my dream is, again, that intensive care will eventually disappear. How can we achieve this? I think we can achieve this through something called precision medicine. And many of you have heard about precision medicine. It's really the sort of convergence of three things. One is clinical and mechanistic insights, right? So hypotheses about health, about disease, together with data, which increasingly is high dimensional. And then the third piece is, of course, statistical modeling and increasingly artificial intelligence. I think this trifecta is really driving precision medicine and will allow us to make better decisions and achieve better outcomes. I think there's still a lot of things that are missing in this vision. And one of them, the sort of most fundamental question is, how do we achieve medicine that is both, personalized as well as precise? And the reason I ask this question is because, in data science, people talk about the curse of dimensionality. I think we face in healthcare and in medicine another curse, which is the so-called curse of heterogeneity, right? People are biologically quite different. And this poses big problems. It poses problems in terms of classification, diagnosis, and treatment, and prognostication. So how do we solve these big problems? I think AI will play a big role in solving. I think as far as my own activity is concerned, we've been using big data, sort of large, complex data sets to do three things. One of them is to understand networks. So networks, for example, in the brain, how the different parts of the brain interact, as well as signaling networks. That's one thing. The second thing that we've been focusing on is decoding time series to sort of understand clinical and physiologic state transitions. And then the third thing that we've been working on quite a bit is phenotyping, understanding, in a sense, the relationship between the outside and the inside. So the external sort of observable characteristics of individuals, how do they relate to what's happening inside them physiologically? So I think I'm running out of time, but that's basically what who I am and what I do. And I'm more than happy to engage in questions with the audience and with the other panel members over the course of this session. So thank you.
Thank you, Professor Stevens. Next up, we have Dr. McCoy. Dr. McCoy, as a bridge between neurology and AI, your position is crucial, and we'd love to hear about your work regarding this topic and AI. Thank you.
Yeah, absolutely. I mean, I think my stance on this question, or my work, can be most succinctly summarized by ensuring machine learning for healthcare works for all. So what do we need to do to make sure that these systems work for everybody, the patients that need them the most? What can we do to make sure it gets out of the high-tech labs of a few hospitals in Europe and the United States and actually into working with the various patient populations that need it most, whether that's in underserved areas in the community, whether that's in countries around the world, but also whether that is for even within patients within those same hospitals. How can we use artificial intelligence to counter bias and improve quality of care rather than exacerbating bias? And it's a topic I'm happy to speak a little bit more about at length, because I think that's one of the most important things clinicians need to understand, is that when you have systems that are designed to reproduce the existing care context, it'll also reproduce all of the inequities and challenges in those care contexts. So I see this as a very high leverage point for medicine to be able to change the entire system for the better and to be able to build sort of focal points upon which we can intervene. Another kind of area of focus for my work is understanding the specific challenges that arise when artificial intelligence systems kind of collide with clinical reality. So what is the difference between the nice sandbox in which you trained it and the reality in which it's implemented? Again, here I think it comes back to education, because there's this question of human-computer interaction. How do the physicians interact with the machine? Are the physicians willing to call out the machine if they don't think they agree with its recommendation? Are we going to lose skills in this process? There's a lot that I think we can learn from fields like nuclear engineering and aviation in particular, because I think both of those have dealt with a lot of these automation challenges over time. Another kind of area I'm interested in is specifically with respect to medical education, is kind of demythologizing artificial intelligence. I love it. I'm excited about it. I'm hyped about it enough to want to spend my career on it. But I think it's important to understand this technology appropriately in its historical context. So, looking at the history of evidence-based medicine and precision medicine sort of through the 80s to early 2000s, looking at what's new about this technology and what's not new about this technology. Physicians need to understand how to practically use a lot of things that they might not know the details of, whether it's the particle spin physics of MRI or whatnot. And we've been using clinical algorithms for years, whether that's something simple like the 4-value SOFA score, or whether that's something complex like a multi-thousand value artificial intelligence system. And the last kind of area of interest and focus for me is this sort of meta science question of how do we build an environment where we have open, inclusive artificial intelligence, particularly as we have the rise of large corporations really dominating this space. I think it's important to look at how we can have bottom-up, open and inclusive efforts. I've been involved with the MIT Critical Data Group on hosting datathons around the world, on promoting and building open data sets, and really just sort of hoping, again, in interest of making sure it works for everybody, that we can build AI systems from bottom up rather than just from top down.
Yeah, I do agree. And building on that foundation, I would maybe ask Dr. Ercole. Thank you for joining us again this session. With your blend in clinical expertise and a strong foothold in informatics, could you briefly share your short story with us?
Yes, of course. No, thank you for the invitation. Like Robert, I'm also a neurointensivist, and my sort of interest is in traumatic brain injury. But I also work as a chief informatics officer in my teaching hospital, and so I kind of have two hats really. I've got a research hat, and I've got an implementation hat. And to speak to the research hat, I would entirely agree with the comments that Robert made earlier. And one of the things that's really interesting about intensive care medicine is nothing works. Okay, so all clinical trials are generally negative, and which is all very disappointing. And some of that is to do with the heterogeneity of the patients that we have. I mean, outside my area, one of the important concepts in intensive care is sepsis. But the concept of taking 1,000 septic patients. Well, what do you mean 1,000 septic patients? What age? What sex? What organism? Where in the body? How long for? What treatments have they received so far? All these things make it a very, very difficult problem to do randomized controlled trials. And I think some of the solution does come, well, I hope, from data, because we are a really data dense patient episode. So some of it is about precision medicine, about phenotyping patients and identifying groups of patients who may respond differentially otherwise are just washed out in our clinical trials. Some of it's about understanding the disease from a data-driven perspective. And the data is complicated. It's inherently time series data, and wrapped up within that time series data is a whole raft of information that is not appreciable to the human eye. And indeed, that's another sort of area that I think is really important, because one of the most important things in medicine to do is not screw stuff up, bluntly. And actually, one of the areas of medicine which has the highest rate of avoidable harm is critical care. And that's not surprising. Our patients are really sick, and some of the stuff that we do is really dangerous. And generally speaking, people don't come to work to mess something up. They come to work to do a good job. But the reason something went wrong is they didn't have access to the right data at the right time about the right person to make the right decision. And what we did in the past is we simply ignored most of the data we had because it was all on paper and it wasn't accessible to us. Now we have the reverse problem, which we have so much data available about the patient that we are almost drowning in a data deluge. And so another aspect of AI and algorithmic kind of approaches for me is to take some of that data but reduce its dimension in a clinically meaningful way, so that we can actually start to see some of the wood for the trees, because human beings will never be good at looking at multiple signals over time with complex interrelationships that are clinically meaningful. So that's kind of my interest in the research and the AI kind of aspects of this. But I also have an interest in implementation across the whole of the hospital. So my remit as CCIO is to try and use digital generally in improving healthcare. And there I'm minded to think about a number of other aspects to this. One is the safety aspect and how we actually go about deploying healthcare solutions. And it isn't just about the accuracy or precision recall of a particular algorithmic solution. And those things are very important, and users are going to have to understand that. There's an educational need here. But it's also about how these things perform in real deployment. So what happens if these things go wrong? What happens if they're not working? What happens if they fail? What happens to the system then? Making sure these things are inherently safe. So there's a huge amount of work about actual deployment in the wild as well.
Okay, perfect. Thank you. I look forward to your views on our our questions. Last up, second to last, we have Mr. Laupichler, representing our educational foundation of our session today, and also adding a psychological note to our medical narrative. Could you please tell us about your work at the University of Bonn?
Yes, thank you so much for inviting me, and I'm looking very much forward to the discussion. And I think these diverse standpoints are going to be very interesting in answering the questions that will arise in our discussion here. So, like Tim introduced me, I'm Matthias Laupichler. I'm from the University Hospital of Bonn in Germany, and when I'm introducing myself to people, I'm using the metaphor of having two hearts beating in my chest, which obviously might be a little bit anatomically incorrect, but nonetheless, I think it represents how I feel about my two main research areas. And the first one being that I'm conducting research projects in the field of medical education. Since I'm a psychologist, this is like my expertise, not the clinician side. And well, my research in this area mainly focuses on digital skills that are required for the delivery of healthcare services. So I'm basically asking how to educate medical students in a efficient and in a safe way about technologies that are essential for delivering healthcare. And now, my second heart that's beating my chest, my second research area is that I'm investigating the so-called AI literacy, which can have something to do with medical education, but doesn't have to. And AI literacy basically means AI knowledge and skills that everyone should possess, no matter if they are a computer scientist, a clinician scientist, a nurse, a physiotherapist, like basically everyone. And I think that's a very important groundwork and base work, like this general AI literacy, on which we can build and then add medicine-specific AI competencies, which we will talk about later, I'm sure. And well, in the last few months, I basically developed a way to measure AI literacy. So one of my big big guidelines is that you can't improve what you can't measure. So we developed a questionnaire, an assessment questionnaire that is valid and reliable to assess AI literacy in medical students, but also in other professions, as I think that AI competencies, especially in the healthcare context, are interprofessional and interdisciplinary in nature. Yes.
Thank you. I think your metaphor of the two hearts for medicine and for AI speaks to many of us in this panel and in this chat room. So thank you for that. And last, but certainly not least, we have Professor van der Schaar, the brains behind the Center for AI in Medicine, also inventor of these impactful sessions. We're honored to conclude our introductions with you, Professor. Could you please share your experience with the integration of AI into the world of medicine?
Thank you, Tim. So as you all realize, I am the machine learner in the room, the geek in the room, representing the other side. I have worked prior to machine learning in healthcare in many other areas and domains, from smart cities to education, and from ML from smart cities to education to finance to networks. But around 8 years ago, I started to really be interested in medicine and what AI can do to empower clinicians like you. And the reason that I'm so excited about this area, and I think that this is the area I will stay with for the rest of my career, is not only due to the impact, the positive impact on the real world that you, the clinicians, have, and the desire to empower you with tools to better use technology to get better patient outcomes, but also because medicine is very complicated. So unlike almost any of the areas that I have worked on before, where I develop machine learning tools for empowering these different areas, medicine is so unbelievably complex that took me in a journey in machine learning to look at everything from time series to causal inference, from causality to discovery from data, from phenotyping to digital twins and synthetic data, and also the human-machine interaction and safety, as well as biases. So it is an unbelievable area to really work in. And I'm very excited about the possible collaborations between clinicians and AI researchers like me. I find it, though, also a complex area because we come from very different domains with very different language and very different expertise. So I'm very passionate about building this bridge between our two communities, such that AI researchers like me are indeed engaging with the real problems you want to solve and are capable to understand your needs and empower you by jointly developing tools that could be useful for your patients. So this motivates me, and I thank you again for being part of our session.
Thank you so much, everyone, for your introductions. As we're moving on, we would now start to really go deep into AI for medical education. And first big topic that we want to talk about is what are actually the necessary skills that clinicians should have to use AI in a meaningful way. And again, we will start with a participant poll to see what you think about this topic. So please, you can all start voting. Yeah. Great. So we had two questions here. First of all, we wanted to know, should we focus more on theoretical or practical skills or both? And actually, most people, 77%, have answered that we should focus on both practical and theoretical knowledge. Secondly, we also asked about the level of AI skills that future clinicians should possess. And most people advocated for a proficient level, the ability to understand, not just use AI tools, but not the ability to develop AI tools as a machine learning expert. Without further ado, I will hand it back to Tim so that we can hear more about this from our great panel.
Yes, very interesting results to see. So let's move on to our first question. What are the most crucial AI skills that future clinicians should be equipped with? Given the depth of their expertise in both the practical implementation and theoretical roots of AI in medicine, I'd like to first direct this question to Professor Stevens and Professor van der Schaar. Professor Stevens, with your hands-on experience in informatics and precision medicine, could you share your insights on the necessary skills clinicians should be looking to gather?
Yeah, so I think my personal view is that AI is an extraordinarily valuable tool that helps us to solve problems. But I think perhaps the most important skill is posing the right questions and framing the problems appropriately, so that we can then implement solutions that use AI. So I think once you've established a sort of appropriate problem space, then you can start thinking about what sort of tools are needed. And I think we all agree here that AI is very powerful, but perhaps not necessary for many of the issues that we face in medicine. It is a very powerful tool that can be implemented for data intensive, complex issues where there are many degrees of freedom and where it's sometimes challenging to solve using simple mathematics or statistical modeling. So I think once the problem is posed, then I think you need to start thinking about the methodology for solving it, and it may or may not imply AI. I think the skills that are needed to understand AI and to implement are certainly a strong, of course, basis in mathematics and a passion for statistics and probabilistic modeling. I think those are probably key aspects that I think we'll talk maybe more about this today, but should be reinforced in the curriculum for medical schools. I can tell you that the medical school I went to, we had mathematics, we had physics, but I'm sure that it could be much more developed for the physicians of today and in the future.
And Professor van der Schaar, following that from an academic and research standpoint, could you illuminate how the foundational AI skills that our future medical professions should be well versed in? How would the future look like for medicine?
Thank you for this. I'm going to take probably a controversial position here. And I'm going to say that I believe that it is upon us, the machine learning researchers, to build tools that require understanding, but not necessarily complex mathematical or statistical knowledge from the clinicians. What I personally think is the clinicians need knowledge about what these tools really are capable to. But the reason they need to understand it is to imagine what possible futures look like and imagine innovative ways to use these tools. I'll give an example here. We developed a tool for risk prediction that we described quite a lot in some of these sessions. And it really required a brilliant clinician rather than a brilliant machine learner to understand that this tool can not only be used for risk prediction, but also for screening to determine the value of the different types of information that's available for screening and assess its impact. So I think that what is very important is a dialogue between the clinicians who have problems they need assistance with the sake of technology, and machine learners to truly understand these needs and build together tools. But I think that especially with copilots, with the world of ChatGPT, increasingly there is really no need anymore for formalism, for very strong potential mathematical skills, because we have other ways to really transfer knowledge among the different domains. What we do need, though, is the realization that the field of AI is moving rapidly. So hence, what was not possible today may become possible tomorrow. And more than that, to throw challenges you have to us, the machine learning community, to see if we can build tools for you. An example in my own case comes from a few clinicians in our Cambridge Center for AI in Medicine, in particular, Dr. Alex Gimson, which is a practicing clinician who was always very interested in variation in practice in medicine, both desired and undesired. And at the first look, machine learning is quite incapable to really reason about the different sources for such variation. Yet it became very apparent that we could co-develop tools to do that. And that goes beyond conventional machine learning tools like reinforcement learning or inverse reinforcement learning. It really brought us into a new agenda. So what I'd like really to bring to this discussion is, number one, I think it is even more important for clinicians to understand what's possible and then co-develop and dream what they need, and then request from technologists, inclusively machine learning, but not only machine learning, the development and co-development of tools. And what I think is really important in a world that's moving so fast, like the world of AI, is to have continuous education. Because while the tools that we have today may be at this level, it is my belief and hope that the tools will rapidly evolve. And it is extremely important that you, the clinicians, are in the driving seat and not with the technologists. Because we love technology, so the more is the better, but at times this technology may be useless, harmful for your patients. And hence, I think it's very important that you are engaged in these discussions, that you shape and drive the technology that we develop.
Thank you. Thank you. It's more like the clinicians are the ones bringing the problem and having the vision, and the machine learnings are helping them to build it. We also had a question from the other audience, Tim Schubert.
Yes, so we actually also had a question addressed from Janet Allen, and they asked whether the difference in how medical and AI papers or machine learning papers are written could actually be one of the roadblocks.
I think Ari put his hand up, or...
Yeah, I was going to make a general comment, but I'll touch on that. So I agree with everything that's been said. And I go further to say that in general, and this is not exclusive, of course, but I'm just thinking in general, it is neither necessary nor perhaps even desirable to try to aim to make doctors into data scientists and machine learning experts. That's not to say that some might not want to do that, but as a general rule, actually, doctors probably should stick to doctoring and think about how that can evolve with tools that are developed by experts in the other domain. And I just wanted to sort of draw an analogy there, really, which is because that then frames what skills are really necessary. And I would want to draw the analogy to clinical trials. And I expect myself and my colleagues to practice medicine as informed by the best evidence that is out there. And one form of best evidence are clinical trials. It has problems, but it's the best kind of evidence. But we all know that clinical trials don't necessarily generalize. So I would also expect all of my colleagues to read clinical trial evidence, or be capable of reading clinical trial evidence with a critical eye, critique that, and understand where the limitations or the generalization of that clinical trial would be. And that actually may require some technical matters. For example, I would expect every doctor to understand what a p-value is, at least to some level. But that's the really crucial thing here. And so I think there is a literacy that's required to come to the point about the way that papers are drafted and written. A basic literacy is required to the point that allows every clinician to appraise and critique particular AI solutions, because otherwise you run the risk of inappropriately using inferences from AI when they don't apply, or reinforcing biases amongst communities, and all the things that other speakers have already spoken of. So I think it's that basic AI literacy that needs to be acquired.
Could I please jump on this, because I'm curious about the panelists and what do they think about Janet Allen's question, which I think is a very, very good one. I think it is almost impossible, and we shouldn't want to align the publishing skills of medicine with the publishing skills of AI. we are in a very different set of communities. And in AI, for instance, we are publishing at very fast pace. We are publishing without knowing who the authors are in a double-blinded fashion. And I think that this is a good practice for the community. And I think the clinical community publishes in a very different way to comply with different levels of rigor. The question, though, that I have to the other panelists is what they're thinking about the interface. Because I think what publishing the way we used to publish so far works, but if it is to publish at the interface, how to do that in a setting in which we need to have the rigor of the medical profession at play, at the same time, a very open mind to accept and investigate new technologies. I'd be quite curious how the clinicians think about this in the middle world.
Yeah, I mean, I'm happy to jump in here. I think this kind of addresses one of the other questions as well that somebody had asked around this question of sort of people at the interface and how you can have people who are trained and expert in both, and how you can function there. And I think like the optimal for creating and developing these tools is going to be driven at its core by, I think, people with dual training. I think it's becoming increasingly feasible. If you're a medical student now, you're not going to be practicing as a staff physician probably till the mid-2030s. And I think, over this time, this question of like, do the jobs exist? Will the jobs exist? The jobs will absolutely exist. If you are willing to pursue this training, the demand is going to be there. And I think that's a problem that's going to sort itself out. And so I think that there is a cohort of people, striving to learn as much as I can to be one of them, who can read both of those papers that Dr. Van Schaar points out, who can read the mathematical formalism and then, okay, what does this mean in a clinical, come with clinical examples, and then design a trial around it. I think a lot of the core of driving forward machine learning research is going to have to involve people who can understand the interface and who can sort of read both sides. But what I think is also true is that that is certainly not everybody. And I think it was Dr. Ercole who said, it's not desirable for everybody to develop those skills. For most physicians, learning how to read the mathematical notation in a computer science paper is frankly a waste of their time, because the majority of physicians are not scientists. The majority of physicians are clinicians and practitioners who are dealing day-to-day with patient interactions. And so for those people, I absolutely agree that the more traditional style of medical paper is really important. Something that says, okay, here's the system we developed. Perhaps you have a different paper that mathematically formalizes it, does all the machine learning things. But what matters to the clinician is, here's the system we developed, here's the patient population we tested it on, and here's how it performed. And I think that a lot of this sense of deep understanding, explanation, so on, is more important for driving the field forward. But when it comes to actually using it on a day-to-day basis, it comes back to, how do I apply this? What's the evidence for it? And again, I think we're not in novel territory here. If we look at medical physics and a lot of the innovations that happened in imaging, I mean, in neurology, we look at imaging all the time. We look at our own imaging, we look at radiology reports and so on. But I really only have a rudimentary grasp of particle spin physics, because that's not what I'm thinking about when I am dealing with it clinically. If you are a researcher who wants to drive forward the neuroimaging world, you need that PhD in physics and so on. But to use it clinically, you just need to understand sort of who it works well for, who it doesn't work well for, can I apply this to my patient, and so on. And so I actually think this idea of fusing the papers in certain very specific contexts will become necessary. But I think more it's going to be kind of linked papers with both technical description in one document and then another document that sort of outlines how it was validated clinically, in the same way that we've already bifurcated things for, say, drug development or imaging.
Liam, I'm sorry, I need to jump on this and say, it was I said that I don't think the clinicians need to have the knowledge of mathematical formalism, math, and statistics to be able to drive this revolution of AI in healthcare. I want, as the machine learner in the room, to be on record that I have said so, because I really don't think you need to come to our world.
I would agree with that. And I think, you also have to ask, what is it we're trying to achieve, right? So there's actually a continuum between, it's very much like drug discovery. Yeah. In drug discovery, we have laboratories that are largely automated on one end, producing huge numbers of target molecules, which are then screened. And then a smaller number of those get through to the next phase of something to see if they have some biological activity. A smaller number get through to the next phase. And then an even smaller, and it's like a funnel. And then we get to the phase 1, phase 2, phase 2A, phase 2B, phase 3, phase 4 sort of studies of the drug development path. And it's a continuum. At the drug, the molecule discovery, you want really fast-paced, new algorithms, new things, just new. Let's see if any of these are exciting, and anyone thinks of an application. That's in the domain of the machine learning. On the other end, at some point, you have to demonstrate these things actually work in human beings in a human trial, and it's entirely analogous. And so the skill sets that you need and the understanding that you need will depend on where you are fitting in on that pathway, on that discovery pathway.
So just I could just maybe add a comment. I agree completely with Ari that clinicians need to have statistical literacy to be able to read and appropriately interpret clinical trials and other published data that appears in the biomedical literature. But I would take a slightly contrarian view with respect to what Mihaela was saying, in the sense that I also believe that by and large, physicians need or have a compulsion to understand things before they use them, right? And so this ties in with this question of trust. And I think that if you present to clinicians algorithms that are perform at a very high level, but which they can't understand at all, they don't have the tools, the basic sort of statistical mathematical tools to understand. I think they might be reluctant to use them. They might actually say, I don't understand what this is, I'm not going to use it. And so I think we obviously need to think together about what is the appropriate level of understanding that is needed to enable widespread implementation of some of these algorithms that are extremely valuable but require trust.
Robert, I just want to say I completely agree with you. So I do think that this issue of what level of understanding is needed. So Ari mentioned about p-values and a certain relatively minimalistic way of understanding clinical trials. As somebody who does research on machine learning for clinical trials and trying to understand what statisticians do, clinical trials, as we all know, you know much better than me, are unbelievably complex. And yet it is only the results that we require clinicians to understand, not the whole pipeline that the clinical trial involved. In an analogy, I would completely agree with you, Robert. I'm sure that clinicians need to understand what we develop. The question is at what point and at what level this understanding should be there. But what I also want to say is that I feel that they should understand enough what the technology can do to drive it. And that's something we talk much less about. So often we feel that, I feel at least, that the clinicians are given some tools and kind of either pushed to use them or they need to consider to use them. But what I think is more interesting is for them to understand what the technologies are capable to do and invent new ways, or put their researcher hats and their inventors hats to drive technology in a way that they think it's useful. And that, I think, will be very empowering for clinicians, because then they are in the driver's seat, but also will be empowering for us, the machine learners, because you are going to give us interesting ways to think about our own world and new tools to build with your perspective.
Yeah, and I also wanted to hand this off to Matthias too, because he's very well versed in AI literacy, as I understand. So maybe Matthias?
Yeah, I wanted to add something about the recent trend in AI literacy, which is to distinguish between three main areas of AI literacy or AI knowledge and skills, which is like AI literacy for everyone. So no matter their profession, even outside of healthcare, outside of computer science. And then we have the AI proficiency, which I think you also used in your poll before. And I think most clinicians actually fall under this umbrella term of AI proficiency, because it's domain specific. And I would actually argue that that mathematical skills are in some way do fall into this category. And then you have AI expertise, which is people that develop AI models. And I think most physicians, most clinicians will not reach that level, because they just don't have to. There are other people like Mihaela and other people who are developing machine learning models, AI models, And so I think most clinicians would actually like to stay on this AI proficiency basic level, not basic level, but middle level.
Okay, thank you so much. Holly, has their hand raised. Would you please post your question in the chat? That would be great. And or I haven't seen it so far. And we also had one question from Marco Montagna, which I think is very interesting. I'll just post it in the chat again. So this is apparently output that you would get from using Autoprognosis 2.0, actually a software that Mihaela's lab has developed. And would you say that this is the kind of level that would be sufficient if you would understand this output? Or do we actually need more skills, or maybe even less skills? Should this be easier to read? What do you think on that? Yeah, please go ahead.
Yeah, I think it depends on what you're wanting to do. Yeah. So if you're wanting to develop an algorithm and put it into practice, then I think you do need to understand such things. But I think we need to separate that from the general level of knowledge, which is what you need to do in order to use such an algorithm. Because at the end of the day, these are for the birds unless we actually start using them. The general level of knowledge to be able to safely use something in your clinical practice is a very different bar. And I think, again, if I can just take the analogy, and I think Robert's absolutely right. It's about trust at the end of the day, and trust is not a binary thing. We have a certain level that, in fact, we call it the 5%. We trust something in the medical literature. It's exactly the same thing as when I read a trials paper. I begin with the mindset that I don't believe this, that there's a problem with this somewhere. And if by the end of reading the paper, I haven't found the problem, then I have some level of trust in the thing that I'm reading. So it's about I think what people have to have is the sufficient knowledge and understanding that they can read such a thing and formulate an opinion as to whether they trust what it is that they're looking at, which is a little bit about its performance, but it's also about its understanding what's happening under the hood. It's not quite necessarily the same as actually being able to write it from scratch.
Yeah. I totally agree with all of you. And it's very interesting because this might be a question for a session on its own on what the key criteria are for clinicians to evaluate medical AI papers. I think that will be really interesting for the future. But I see that we have to stick to our time schedule. We could talk an afternoon about this if we wanted to, but we're gonna have to move on partially. But first, I think we're gonna do a poll just to gauge where the participants are.
Yes, exactly. So just to tie the sections together, here's a poll on when you think medical students or even medical professionals should actually learn about AI. What you can see here is that apparently the pre-university level is not preferred, while most people think it should be part of medical education in the preclinical or clinical context, but rather less later on. And this is interesting because in the next two sections, we will actually focus first of all on how AI education can be integrated into medical curricula at medical schools. And secondly, we'll focus on the way we can empower doctors that are already in the workforce with the skills necessary to efficiently leverage AI. And to get us started with the medical education, we would again like to do a little poll. So most of the participants today, actually 87%, think that existing medical education does not cover AI sufficiently, which is great for our discussion, actually. And secondly, the majority of people think that AI education should actually be compulsory within medical education. And I'm very excited to hear what our panelists think.
Yeah, me too. I would like to address this for a question to Mr. Laupichler, because your background in psychology and medical education at the University of Bonn, how do you envision this integration? What do you think? At what stage do doctors and medical students need to start learning about this?
Yeah, so I actually think they should start in the very first semester of university and then have a longitudinal track that's focused on digital competencies and on AI competencies. But I also think that that medical education should integrate AI education into other disciplines, like education about other disciplines, just like we do with the electrocardiogram and all the other important tools that clinicians use. I think it's actually the same with AI. So using AI tools in the context of healthcare has in my mind the highest impact on learning about AI and the pitfalls and the chances and the advantages of using AI in healthcare.
Please, Professor Stevens.
So I completely agree with Matthias, and I think there should be a sort of data science AI thread that is embedded in medical studies from the very beginning, from day one. Now, it also partly depends on how studies are structured. So, for example, in the US, as you know, students have an undergraduate curriculum, which is sort of pre-medical, and then they go on to med school. And this offers interesting opportunities, right? Because we're seeing an increasing number of folks coming to medicine after having studied fields like computer science or engineering or mathematics as undergrads, right? So they have actually quite a sophisticated set of skills and competences, and then they enter medical school, perhaps well equipped to understand and implement data science methodologies. So that's one paradigm. Certainly in many other countries of the world, medical school is a single curriculum that begins right after high school. And in those cases, I think it's the case in most countries of the world, I think the AI curriculum should be fully embedded, fully integrated from the very beginning. It should be, I think its importance should be reinforced. I can tell you, because I'm quite familiar with medical education here in the US and to some degree in Europe, I think the current level of AI education is very, very insufficient, and we're not training the doctors of tomorrow to be proficient in this domain. So there's a lot that needs to be done, in my view, to reinforce this.
I completely agree with that. In fact, I was having just this conversation with my medical school just earlier today, actually. I think there's a comment in the chat about lifelong continuous learning. I think that's really important. So let me work backwards. I think that there are different needs at different stages of your professional career. And so now, as someone that's practiced as a consultant for quite some time, and I've worked not just in the ICU, but in the hospital, and I have a better understanding of how hospitals work, how medical systems work, I think I have a very different set of understandings and thoughts about where AI may fit into this situation, and have different ideas. Working back, I completely agree with all the points about medical school, but I'm going to go even back before medical school. And I'm going to take this now outside even the context of medicine, that I think actually, since AI and our algorithmic technologies in all aspects of life pose a likelihood of changing everything we do, and indeed pose a number of threats as well, which I think we just have to recognize. That's not to say that we shouldn't pursue things, but there are threats that come with new technologies. Then actually education into these things needs to start at a very early age and just becomes a continuum for those people that go into medicine, that there isn't a medical aspect to that. But I think it's critical for everybody through society.
And let's finish with Dr. Liam McCoy for this question.
Yeah, there's one kind of piece I'd like to add here, because I think I thought about this a lot. I'm relatively early in my training, early in my career. it's important, like, recognizing that we have a lot of uncertainty about what the future is going to look like, that things aren't bounded. And I think the biggest mistake that can be made is focusing too narrowly on what the issue of the day is. So, you know, if it was, I don't know, 2012, you'd be teaching about a completely different set of medical AI methodologies. If all we focus on now is transformers and LLM, you know, 5 years from now, there could be another innovation that throws all of that out the window. And there, a general piece of advice I try to live by is sort of, you know, don't train or strive towards a specific outcome, but train or strive to become the sort of person that that outcome happens to. I think the former says, okay, I'm going to learn XYZ technology, I'm going to learn how to code in this language and so on, and get to that goal. Whereas the latter is more like those sort of fundamental concepts as some of the other panelists have alluded to. And I think that, you know, is the challenge. It needs to be our focus. You can sort of elucidate it through case studies, you know, understanding natural language processing by understanding GPT models as a case study, but we've got to really not get bogged down, which I think medicine can sometimes do, on building a big elaborate training module that's immediately out of date in the 5 years it takes to get implemented to the program.
Yeah, thank you. And I also see, Tim Schubert, that we have a really quick question from the chat too.
Yeah, actually a very important one, I think. Will Halfpenny asked, since medical students' time is already quite maxed out, usually with existing curricula, do you think there's anything that could make space for AI to be implemented there?
As someone who just recently finished medical school 2 years ago, I think I can speak a little bit to this. I think we also need to look at the things that AI is going to make more important, but also less important. And it's becoming increasingly clear that rote memorization of facts is a much less important aspect of doctors' day-to-day. We have tools, things like UpToDate and so on, that allow us to consult the latest evidence. I think there are still a lot of clinical scenarios where you need that snap knowledge, that snap judgment. I don't mean to say that doctors should know no facts, but I think certainly in Canada, our medical education emphasizes a lot more clinical skills and spends less time on memorization. Right now, I'm writing the United States medical licensing exams as I want to go south for fellowship. And there's just so many, you know, this disease from this part of the Ohio Valley, you have to know the name of this bug and so on. I think a lot of medical students' time is spent on factual knowledge generation that made more sense when you have to consult the textbook, but makes less sense now with the way technology has changed. I think AI is going to further that. So a shift less from knowledge and more towards skills, I think, is the broad shift, and it'll happen here as well.
Yes, professors.
So maybe I can jump into I think the question of William is a very important one. When should one bring this type of education, given the fact that students are already maxed out in terms of time? And I wonder whether, and again, since I'm not a clinician, I can just wonder whether solutions that have worked in other fields could work for the clinical field. For instance, summer schools. In Cambridge, together with Ari and others, we are running a summer school every summer, partially to try to bring together machine learners and clinicians to discuss about this issue. So it's another one could be just internships. And yet another one, I think, is to have you clinicians come to our world, the machine learning world, and educate us about the complexities of medicine and the needs you have in terms of transparency, in terms of trustworthiness, in terms of accuracy. So I think that what we need is on both sides. On one hand, I think we need to have a variety of ways in which we educate, not only in terms of curricula, but also potentially summer school, internships, and so on. And also I'd like to inspire you, the clinicians, to consider coming and educating us, the machine learners, about your needs, and possibly create and co-develop joint training programs where people, like I think Liam was saying, people at the interface are trained together, such that almost similarly to how MBA programs at times bring together business people and technology people, in a similar fashion, bringing together machine learners and clinicians together.
Yeah, I would just add that if you look at medical school curricula, I mean, I'm very familiar with the medical school curriculum here at Johns Hopkins. There's a lot in there that is extremely valuable, but there's probably quite a lot that could be taken out. And I think what we need is maybe to build on what I think exists in most medical schools, which is a formal curriculum in biostatistics and research methodologies. I think what we need, is to build up that curriculum and integrate AI, which in many ways builds on statistical knowledge, much to the regret, I think, of one of the persons who was commenting in the chat that it was the most hated course. I think we can make this a course that people like and understand and want to implement and put into their practice. So I think it should be built into the curriculum. I can give you an example from here at Johns Hopkins. I was recently invited to set up a course for informatics and AI for the School of Medicine, for the 3rd and 4th year medical students. And I answered saying, well, how much time do I have? And they said, you have 3 days, right? 3 days out of 4 years to teach AI, informatics, and whatever. And so it just gives you a sense of the priority that the leaders in the medical schools are giving to this topic. It is woefully insufficient, and we need to build it up, and we need to be convincing and persuasive that it's going to take more than 3 days for medical students to gain a foothold in this area.
I agree with all those points, and I think just to flag that everyone learns a little bit differently, and everyone's needs will be a bit different. Everyone's interests will be a little bit different. Okay, so I think Mihaela makes a very good point that we need to offer. There'll be multiple offerings, and they will appeal to different people who want to have different outcomes. From a medical school perspective, I think if I could criticize my own profession a little bit, that there is a lot of history in many things that we teach at the moment. I suspect that in 100 years' time, people will look back at this time and say, can you believe that doctors put rubber tubes in their ears? And I know it's amazing, isn't it? So things do evolve, right? And I think one of the things we're really, really bad at in medical education, or certainly my experience, one of the things that's difficult is a tendency, let me tell you everything I know about this thing. Actually, I don't want to need to tell you everything I need to know. What I need to do first is think, what is it you need to know in order to, first of all, perform your job, and secondly, to make sure that you have the opportunities available to you if you so choose, so you understand that these opportunities exist, and then build a course around that within medical school. And then there are other opportunities for those people who wish to take things further. That's kind of my view on how we should devise these things.
Yeah, Dr. McCoy, really quick.
Yeah, just one last little thing to add. I think the extracurricular component, as has been alluded to, I think is really important. I know some folks in the chat discussing an AI in Medicine Student Society. Like, I think the things that are less seen as evaluation and less seen as more work, but more rather seen as things that help to inspire students, help get students excited, I think are really important. With MIT Critical Data, we've done a lot of these data-thons, which are like 48-hour, 72-hour events where we give people a data set, give them some questions, make it fun, make it competitive, shove a bunch of clinicians and researchers together, and make it happen. I think they've been really useful. They're useful for me. They're useful for fostering community. They're useful for fostering those connections. And I can happy to share my contact info. If folks want to reach out, I think if there's a robust group that's really dedicated to doing the work to host one of these things, I think we'd absolutely, we're always adding them to the schedule and times forward. So I think we'd be love to collaborate.
Yes, thank you. We'll still have to move on to the next question. Just like Professor Stevens says, 3 days is too short, and this session is always too short. But we're gonna do a little poll for the last question too.
And also, while we're opening up the poll, rest assured, we will probably have more sessions like this on AI education for clinicians, since it's such an important topic. Okay, so while we're waiting for the results to roll in, there was actually one more interesting question in the chat. And that is, have any of you ever reached out to medical schools or to your universities to suggest an AI curriculum for medical education? And did you receive any positive or negative answers from the universities themselves?
Yeah, I think it's very positive actually. Certainly where I am, I think there are competing demands with other aspects of the curriculum, and I think there are issues of where to fit it in. And I don't think it fits in one place. I think it actually needs to be a continuum of things. I think you can need to mesh it with other. It's also not just the AI. I think that it needs to be intermeshed with. We talked about ethical aspects of AI. There's ethical aspects all across medicine. So there are cross-cutting themes within medicine where all of these things can kind of come together. I think people are actually very keen. I think people are waking up to it in my experience.
Okay,
I think timing is everything, right? Because I proposed like 5 or 6 years ago a data science curriculum to the medical school, and at the time it was they voted against it, and now they're coming back to me and asking if I can do something, to address this gap, which is clearly which is evident, I think, in our medical school and in many others. So it's a question of timing. I think right now is indeed the time to build these curricula and to integrate them as Ari is saying, across the many different domains that are covered during medical studies.
And indeed, just to follow up on what Ari was saying, not only at times curricula, so what we have tried to do in Cambridge with this Cambridge Center for AI in Medicine is to have an AI clinic where the clinicians can come and ask us, the machine learning researchers, as well as the clinicians such as Ari that are involved with the center, questions about AI. Because I think we need to have also not only an educational forum, but also a safe forum where without cameras, without anything, people can come and ask questions, at times naive questions, at times complex questions about medicine and about AI, excuse me, and we can try to answer them. So I think there are different scenarios again on how we can introduce this education. And an AI clinic, I think, is something that almost anyone can run in almost any medical school.
Thank you. Yeah, that all sounds like great ideas. Let us look at the poll results as well. So actually most people believe that AI education should happen within your medical career continuously, and you should have ongoing education. But concerning whether AI should be mandatory for clinicians, actually most participants voted for no, but highly recommended. So I'm also interested to hear your thoughts on that from the panel. Thank you.
Yeah, maybe I'll just pick that one up. I chose that one. So I think we have to understand also, right, that what we have here in terms of people listening in here is a very biased population, obviously, because it's a population of interested people. And healthcare does span many, many, many different domains, from very, very data-centric domains to more human-centric kind of communicational kind of domains and so on. And so I think different people do have different needs, right? And we perhaps been a little bit guilty about talking about doctors here, but actually we need to think about all healthcare professionals, all clinicians. So I think it's, as ever, it's very, very hard to create a one-size-fits-all solution for everybody. And I think it will vary. I think there'll be some people in which, you could imagine that others are commenting in the chat, that imaging specialties are a really obvious place for deployment of AI solutions. And indeed, it's happening. Whereas there'll be other specialties that perhaps are not quite there yet and may catch up. So I think it varies.
I also wanted to ask Matthias, because he's very integrated into the medical education, what his opinion was about this. Should this be mandatory? Should this not be mandatory?
Well, I actually think that it should be mandatory up to a certain point. Like as I said before, there are certain levels of AI literacy, and I think that every physician should have at least like a basic knowledge and basic skills concerning especially like the usage of AI applications in medicine, but also communicating to patients if they use AI applications like AI apps, for example, Ada Health or something like that. And but then again, just like Ari just told us, I think there are more data-driven disciplines, just like radiology, and more patient-driven disciplines, such as I don't know, psychiatry, even pediatrics, family medicine. I think these disciplines are more like can stay on a lower level, if you know what I mean. So they don't have to get these AI proficiency or these AI expertise like the other disciplines. They're more data-driven.
Professor van der Schaar?
So I would like to propose something to the clinical participants. What would happen if we would introduce AI more related to real world problems that clinicians care about? So almost like as part of the electronic health records, which are now increasingly introduced in many countries, if one brings analytics based on AI that are associated to a particular patient, to a particular disease, with a particular point in the patient journey, maybe this analytics could be first, of course, verified, tested, and tested for their usefulness and their impact on the outcomes of the particular patients. But if they are validated as such and introduced as part of an electronic health record or an electronic health record ecosystem, could that be used also to train the clinicians for that particular use? And that echoes a little bit what Matthias is saying, because I may not want to teach machine learning, like medicine, is very diverse. We have a lot of technology. And what is pertinent at a particular moment in time for a clinician may be very different. So just teach clinicians as they go, as they need to use different tools within the concrete ecosystem and use cases. Would that be a good way to do continuous education of using AI?
So Mihaela, this is already happening, right? We have a electronic health record system here called Epic, which maybe you guys use as well. We have embedded in it an algorithm called TRUES, which is a very simple supervised machine learning tool that integrates, I think, 15 input features and then generates a probability of sepsis or septic shock occurring in your patient, right? So this is continuously running in the background, and the clinicians get an alert on their screen when they're working, saying your patient, is at high risk of sepsis or septic shock. And there's several other similar similar algorithms that are currently in the pipeline and will be likely deployed. But I think we have to keep in mind that already, many clinicians feel a bit bombarded by information, by alerts, by different alarming systems. And so if you embed many of these algorithms, you can imagine a sort of nightmare scenario where it's a bit overwhelming for the clinicians. We have to think, I think, in terms not only of the capacity of the algorithms and their implementation, but also in terms of the cognitive abilities of specific clinicians to integrate a lot of information at the same time. Now, I'd like to just build on this to talk a bit about what's happening in AI right now. In particular, with regards to these foundational or large language models that are able to generate a sort of human-like conversation, right? And I just want to respond to, I think, something that Matthias mentioned, that maybe psychiatry is a long way from being potentially something that could be impacted upon by AI. It turns out that maybe that's not true. Maybe sort of simple sort of psychiatry screening could actually be undertaken by large language models. And then I wanted to just make one last comment, because I know we're soon having to close, but I think the obvious next step beyond language models is going to be this question of artificial general intelligence, right? Which we have sort of human-like reasoning capabilities. What do we mean by AGI? We mean essentially the algorithms that can generate new knowledge, that can generate actually new discoveries that are meaningful in the world. And I think that's coming. And I think medicine has to be ready for that, right? So that means altogether, what does this mean? I think it means that AI is no longer a tool. It's going to become actually a partner that we work with, sort of like an additional person in the room that is actually working with us to help us solve problems, is my impression.
Thank you, everyone. I see that we're gonna run out of time. Tim Schubert, did you have one last one, or are we running out of time?
I think maybe we can have Liam say some final words.
Yeah, I was just going to say kind of, Dr. Stevens kind of alluded to it. Dr. van der Schaar spoke about it earlier. We need to make sure these systems are actually useful to clinicians. I think the issue with alert fatigue is you're bombarded with additional information. I heard we created a model that would pay people when it thought they were about to deteriorate. And I got an earful from my resident friends at in Toronto about how many pages they got overnight with information that they didn't feel was actionable. And I really think that there's kind of two paths forward if we want to achieve this. One is, as Ari alluded to earlier, needing to do the sort of dimension reduction that I think is clinically actionable. So rather than just throwing more information at you, if we could have like a validated tool that says like, hey, this guy's ready for extubation even earlier than you thought at the ICU, or hey, this guy's respiratory collapse is imminent, like sort of something that is able to give you a concrete target and recommendation on the one side. And on the other side, I agree with Dr. Stevens. I have huge amount of enthusiasm and excitement about language models. And despite their limitations, I think one of the potentials of language-based sort of collaboration is getting a better contextual understanding of what a clinician might actually want to know. What is latent in their question? How can we present this information in a way that's useful? And yeah, the goal, I think, the dream is to have an AI that's kind of like a helpful senior resident who might not know all the facts, who you might need to overwhelm at some points, or overrule at some points, but they know the list back inside out. They can present the information that you ask for, when you ask for it, when you need it. And they're a second diligent set of eyes on preventing mistakes. I think we often look at the pie in the sky, AI model that will solve all our problems, but sometimes just an additional useful colleague might be what we need out of these systems.
Thank you all so much for this really, really engaging panel discussion. And thank you also to everyone who participated in the chat and asked questions.
Thank you so much to the Tims for running this very exciting session, and very big thank you to our panelists who engaged in a very, very interesting conversation that could have probably gone on for a few more hours, and I'm sure we will make sure to keep this conversation going for the next few months and probably years. So we would be very happy to have you all back for our next session, which will be on the 8th of November. This session, if you want to rewatch the whole thing develop again, you will see it on YouTube over the next few days, as usual. And as always, if you have friends who you think can contribute to this discussion and to our journey to connect healthcare and AI even more, or would just be interested in listening, just send them to our direction. We can sign up on our website for the future sessions, and I'm looking forward to see you all again very soon. Thank you so much.